welcome y'all back from lunch. Everybody's slowly trickling in the back door. Real quick. And everybody say hi to Ruben, because Ruben's going to get to see y'all wave at him.
Especially with the registration of laboratories as medical device manufacturers. This could be up to an additional $5,000 to $6,000 a year. So this is a great time to get involved with your local organization as well as the NADL. And a lot of folks here in this room, especially removable. And I think if you're a removable technician, tell me if I'm wrong, you spend 50% of your time at the bench and 50% of your time on the phone walking dentists through treatment planning and how to go through it. And I'm not trying to say that to be funny. I mean, that's our role nowadays. It really is. There's a need for it. I've been saying for the last decade, there's been no better time to be a technician. I honestly believe that. The need has never been greater for the knowledge this room has. So, moving on. Wanted to call out this gentleman right here and give him a thank you. That is my father. I've learned a ton from him. It's not easy coming in a second generation. Everybody thinks, you come in at 9 o'clock and go home at 4 and take long lunches. If anybody here has ever worked in a family business, it really doesn't work that way. Flip that 9 to 4 to 4 to 9, and that's maybe a little more like it. But I learned a ton from him, what to do as well as what not to do. But great man, and he's been retired now 4 years, and he's loving life. And then this is the last thing I promised my boys years ago that I would always show a picture of him. This was a couple years ago. I've coached Little League with the 3 of these guys for the last 13 years. California being California, which is why we have, the last stat I saw was 400 Californians moving to North Texas every week. Yeah, we won't talk politics, but politics being politics, our season was trashed. This was 2 years ago. This was this summer. This dude is 6'5" now. I have to look up at him. He thinks it's weird when I come in every morning, give him a hug and kiss. He's like, Dad, you're weird. So life has changed. And I also think in the laboratory side, we're in the fastest changing aspect of our business right now. I like to relate it to Moore's Law. Is anybody here familiar with Moore's Law? It's the law of how technology increases. So it doubles, quote unquote, doubles every year, and the cost goes down. So if you take a look at 1971, that's the year Intel came out with the first processing chip. And if we look at how the processing chip has advanced from 71 to today and compare it to a 71 bug, how many folks here have ever driven a 71 bug? You try and merge on the freeway, how long does it take? Especially here where it's 75, I love that. Yeah, it takes about a year. So if this VW bug had advanced at the same rate as an Intel processing chip, it would go 300,000 miles per hour. You get 2 million miles per gallon, and you could buy a new one for 4 cents. So I don't think we're at that rate right now, but we're pretty close to it. It seems like every day there's something new technology, new techniques. So it's a lot of fun. It's challenging. The next hour and a half, I'm hoping we can kind of spend a couple minutes going through some treatment planning, the when, the where, the why. I don't want to spend a lot of time on how. Show you different treatment options, what patients you choose them for, indications, contraindications. We'll go from there. Any questions, please feel free to shoot. Just let me know. Those of you that know me, if I don't know, I'll tell you. If I do know, I'll also tell you. And if another company has a better solution, I'll send you that way. That's the way we do it. So starting off with our patients, our edentulous patients. We know that an edentulous mandible with a traditional denture has 10% of functional capacity. We place 2 implants, put a couple locators, balls, O-rings. We take that patient from 10 to 60. Now, if we can place 2 more implants and have something that is rigid or non-moving, this could be an overdenture bar, it could be a fixed removable, it could be a fixed detachable. We take that patient up to 90% of functional capacity. That's our goal for every case, restore patient function. What are we doing for them? We're giving them the confidence. We're allowing them to eat a nutritious diet. Socially, they say that 50% of denture wearers, these are traditional denture wearers, it impacts their love life. 37% are scared to go on job interviews. Over 28% would not have come to a meeting like this because they were wearing a denture. Another reason we want implants, and again, we want to work with our dentists to try and provide patients more implants. Why? It's not because implants make us more money. What do implants do for the patient besides the confidence and all the other factors? Implants maintain bone. You have more blood flow to that bone. 75% of bone loss happens in the first year of a patient being edentulous. So whether we're placing some little mini implants or we're placing traditional endosseous implants, maintain that bone, that's key. Because you get that case come in the door, you've got that flat atrophied pancake ridge, you're limited what you can do. But if we can get to the patient right away and maintain the bone, we can provide the best possible solution. So we take a look here. I kind of put together a little bit of a chart that we'll kind of follow a little bit today. You know, we have our fixed detachable, AKA our all-on-4 or all-on whatever it's called nowadays. You know, we have a certain interocclusal space we want, a certain number of implants, hygiene, dexterity, prosthesis tissue junction. The patient has to have the funds for it. Now, let's kind of jump down here a little bit to talking about removable. 2 implant locator overdenture. We've talked about that quite a bit. Now, one of the things I want to talk about here is when we're working with our dentists and our surgeons, and we're taking this patient, placing 2 implants in the lower, and maybe 4 or 5 years down the line when they have more money, we can place 2 more. Let's strategically place those locators. Because if you think about it, a lot of the calls we get are, hey, we place there's 2 implants in the bicuspid area. What happens then? You have an anterior and a posterior cantilever. They become peer abutments. You have 2 movements. It's going to be impossible to keep that patient happy. Furthermore, if you go to place 2 implants down the line, where's your AP spread? Where are you going to place the next 2? You have no AP spread. So let's take that into account. We can place them in the canines for our 2 implant overdenture. We have more restorative space, but again, our AP spread is going to be less when we place them distal of that. So one of the biggest trends we're seeing is with the patients we know, hey, 5 years down the line, they're going to have some more money. You know, they can place more implants. Let's place them, you know, anterior to that. Let's place them in the lateral area. We place 2 implants back. We've got a great AP spread. And also, if you think about 2 implants in the anterior, it's only 1 movement. We'll only have that posterior cantilever, that tissue compression. That's easier to handle than the anterior posterior. So, you know, we can treatment plan for the patient now and down the road. So let's jump by this a little bit. We'll come back here. A couple weeks ago, I was talking to a group of dentists, and I told them this is what your laboratory wants to know from you. They have to have an opposing cast. First thing I ask when treatment planning, what's opposing? I want to know what the bite force is. Traditional denture, weak bite force. Zirconia on implants, huge bite force. Patient doesn't have proprioception. They don't have the built-in shock absorbers. They don't have the periodontal ligament. They will continue to overload our restoration until something breaks. They don't have those nerve endings telling them, hey, stop biting, I'm going to break something. So I want to know what's opposing. I want to know the bone quality. Where does this come into play? Can we cantilever? Type 3 bone, very much like styrofoam. Am I going to cantilever off that? Type 1, like oak wood, absolutely I can cantilever off that. General health and patient budget. Do they brux? Do they grind? You know, we'll go through this a little bit. Digital pictures and video smile line. Nowadays with smartphones, I think this is something that we should all be asking our dentist for. An assistant in 30 seconds can take a quick video of the patient going through the phonetic sounds, F, S, 54, Mississippi. And better yet, get that smile line picture. Ask the patient to close their eyes and smile, because you'll find that when the patient closes their eyes, they'll give you a true smile line. Why do we care about smile line? It's going to be one of the 3 indicators of fixed versus removable. One of the 3 key indicators, patient smile line. You can transfer this information through Dropbox. Dropbox is HIPAA approved. It's something we should be asking for every time. This is something I want to know is patient age, dexterity, and hygiene. If I'm taking a look at something that's a conical design that we need to remove every day, a telescopic design, I'm hoping that patient is in that window of, let's say, 40 to 70. I might not present this to an 85-year-old patient who doesn't have good dexterity, or even a 30-year-old patient who might have had a stroke, because we know with that type of restoration, if you don't remove it every day, it swedges down tighter and tighter and becomes fixed. It's one of the big questions. Can the patient clean our restoration? And will they clean it? So this is something I want to know. Diameter length position comes back to AP spread, bruxism, and then the big one in green, because this is where we help our dentists make or lose money. What are the patient's expectations? We've all had the phone calls where, what am I going to do now? The oral surgeon placed the implants, you know, looking like battleships, going the opposite direction, but the patient was promised fixed. There's no way we can get draw. What can we do? What are the patient's expectations? So this is the information I want the dentist to tell me. We talk about vertical dimension. We're not going to spend a ton of time on this. Zirconia, we need 18 millimeters. Traditional fixed detachable, since that's what we're talking about today, we want 15 millimeters. We can get away with 14 for a wraparound. And then, you know, 12 to 14 bar stud, et cetera, et cetera. Bone quality, type 1, your oak wood, we can load it. Oops, type 1, oak wood, dense. Takes about 6 months to integrate an implant. Compared to pine wood, takes 4 months to integrate. Why? You have more blood flow because this is less dense than the oak wood. But with the oak, you put your implant in there, it's not going to move. Type 3, type 4, we need to protect these. either by splinting. It's why in the maxilla, type 3 and type 4 starts earlier than it does in the mandible. We're going to splint this, tie this together with a bar. Now, it's interesting. Last September, almost a year ago, in New York, I was at the ACP meeting, and I was presenting right after a fantastic, I'm blanking on her name, fantastic young prosthodontist from University of Pennsylvania, and she did her research on studs in the maxilla. And I was always taught in the maxilla, hey, weaker bone, let's protect it, tie it together, splint them together. Her research was that there was, I think out of her cases, she did 100 cases, and there was no implant failures and no bone loss. Now, mind you, this was mostly guided surgery, mostly the anterior of the maxilla, but she had phenomenal results, so it made me rethink it a little bit. So when we talk about the difference between the mandible and the maxilla, we can take a look at 20 Newton centimeters of force. How much titanium to bone contact do we need to support that? In the mandible, we only need 6 square millimeters of contact. In the maxilla, 9 square millimeters of contact. So it's why in the lower, all on 4 is great. But in the maxilla, I'd like to have 50% more titanium to bone contact, either longer implants or 5 or 6 implants to support that same load. Taking that a step further, this was a study that showed failures of implants on these. I'm calling them fixed detachables. Is that okay with everybody? Hybrid dentures, all on 4s, fixed detachables. Everybody okay with that? Oh, come on, you guys can't be asleep yet. The lights are on bright. I'm wearing pants for once. It's one of the best things about being in California. I wear shorts every day of the year. Once we're done here, I'll be back in shorts. Yeah, people don't believe it. I mean, Zoom was the greatest thing for me because I could put on like my lab coat and people thought I was dressed up. Oh no, shorts and sandals for everything. Has anybody ever seen any of the tech talks we do? Always shorts, 100%. All right, so this is a study that was done comparing the failure rates of implants in the maxilla and the mandible. Maxilla, almost 10%, lower arch, less than 3%. So again, let's treat the arches a different way. Diameter length of implants, basically we want to know what we can load. Titanium to bone contact. We're not going to load this little mini implant, hopefully, the same way we will one of these wide platforms. Now, one of the worst cases, I should say group of cases, was not too far from here, a state that is close by, and there was 13 patients who had fixed resin bridges on mini implants. And yeah, it was, if we have time, I'll show you some of the slides from that. I mean, the mini implants were tore up, they were infected, they were bleeding. And what the dentist out of Tulsa did, it was awesome. He took these implants, and of course, so much bone was lost, the implant or the implant crown ratio was crazy. So he cut them down, prepped them like teeth, and with these little hollow balls, he bonded on top, took it to an overdenture. It was awesome. Really beautiful dentistry. I can't imagine prepping mini implants in the mouth. It was cool. So, all right, when we talk about arch form, why does this affect us? This comes into AP spread. Why do we care about AP spread? If this is going to be fixed detachable, this has to be fully implant supported. So we take a look at the different arch forms: square, ovoid, tapering. Square gives us a shorter AP spread than tapering. Implants here, versus implants here. The longer the spread, the more we can support. But the big one comes into where we're placing. And again, this all goes back to Charlie English in the 90s. In 1993, he published a paper that said 5 implants in the anterior mandible, we can go 2.5 times the distance. That was early Brandemark papers. Now that probably still holds, but nowadays, we're placing 2 here, we're tilting them. We've learned to tilt implants. This was also done in the 90s. Nobel's done a great job publicizing this with the all-in-4 technique. We're really, when we're talking about AP spread, the distance from most anterior to most posterior, multiply that by 1.5. Here's how much we can cantilever. So if we want 16 millimeters of cantilever, we need close to 10.5 millimeters of AP spread. Now, if we place straight implants, we might have 4 to 5 millimeters between these implants. So we can have 6 to 7 millimeters. we're getting a bicuspid here. We're not getting a full molar. But if we tilt these implants, all of a sudden, let's say we have 10 millimeters here, we're going into the same bone, then we can have both teeth on there. So that's why AP spread comes into account. We want all of our teeth implant supported. Questions, comments, everybody good? I know I'm going kind of fast. So the treatment planning is like a 4-hour course, and I chose like 20 slides I wanted to go through. Yes, sir. That's a good question. Honestly, I flip-flop back and forth on that. The question was, can you have the slides emailed? So about 10 years ago, I would send the slides out anytime. About 8 years ago, I started seeing them all over the place. Then I stopped. And about 3 years ago, I said, okay, I'll send them. Yeah. But what I'll do now is, if you want them, I'll put them in a PDF and send them to you. I'll take out the pictures of my kids because you don't want those. But yeah, if you want the slides, just email me. I'll send them to you. No problem. I'm not too worried about it anymore. All right. So we talked about the 3 indicators for fixed or removable, because this is a fixed course, but it's the biggest trend we're seeing is patients with fixed converting to removable, who either somebody had a hammer and they thought every patient was a nail, or the patient wasn't, didn't fit one of the criteria. So to me, the 3 main criteria we need for fixed: does the patient need lip support? If the patient needs lip support, we can't really provide that with something fixed. We need a flange. If the patient needs lip support, it needs to be removable. Number 2, where's the smile line, that prosthesis tissue junction? We'll see that 80% of patients have a high or medium smile line. If they have a high smile line, that requires reduction of bone. That's a teamwork discussion, the oral surgeon, the restorative dentist, and you as the technician. And I really think when we say the restorative team, I mean, that has changed so much in recent years. The reliance on you to know the materials. What should we use? Can we do this on this patient? So that's why I want to spend a little bit on treatment planning before we jump in. Where's the prosthesis tissue junction? Where's the smile line? This is where that cell phone information, you get the high smile line, the phonetics, the smiling, this is where this comes into play. The third, does the patient have good oral hygiene? Do they have the dexterity and do they have the wherewithal to clean? If they don't have the wherewithal to clean, and a lot of the times if we're not reducing bone, we're providing a modified ridge lap, meaning, let's stay in the anterior of the maxilla, we're compressing tissue because we want to eliminate that hiss and that spittle. 1 in 7 patients spit when they talk, who have fixed cases. So you compress tissue, so you eliminate that black line when they smile, the spittle, that hiss, and you're asking that patient to come in from the lingual, a little tiny opening, multiple times a day and clean. Will they do it? And can they do it? Huge question that needs to be answered. Because if they can't and they don't have good hygiene, heck, and we got 4 good implants, we can go with a bar, we can go with studs. One of the major advantages of a stud attachment, we can independently service it, meaning if something goes wrong with our fixed detachable cases, we're spending time, or our dentists are spending time, opening up the access channels, pulling out the Teflon tape, every single screw is coming out. Whereas if something goes wrong, let's say with the 4 locator case, you can remove the prosthesis, the assistant pulls out the insert, snaps in another one, 5 minutes, the patient's out the door. Independent servicing. So I caught myself. What was I talking about there for a second? This will be good on video. Chris forgot what he was talking about. The other advantage of stud, we talked about independent servicing, easy to clean for the patient. And yeah, we'll come back. I'll remember. We'll come back to it. So when we talk about lip lines, a lot of the times with the all-on-4 patients, you'll see kind of these vertical lines, this sunken look. Patient like this, they need a flange. Restore lip contours. Basically, with a flange, this would be a facelift. This lady would go to church or go to her bridge group or something, and people look at her and say, wow, you look 15 years younger. That's a huge service to the patient. Now, one of the best quotes I recently read was from Gordon Christensen, and he said this a couple years ago, and talking about removable, because with removable, we can replace anything that's been lost. We can handle any aesthetic situation. We lose bone, we have the pink. And of course we can replace the teeth, but the pink can compensate for so much bone and tissue loss. Whereas with fixed, we can only replace the white. We're limited in what we can do. So again, it's not that I'm anti-fixed, even though I'm up here talking about fixed, but these are the 3 indications we need to take a look at before we're working on a patient who can get this. So patient smile line. We talked about 80% having a high or medium smile line. This is the prosthesis tissue junction right here. So if we wanted to provide something fixed for this patient, we would have to reduce this much bone. That's not a decision for me to make, that's for the restorative team to talk about. So again, high smile line, you either need to have something removable or remove that much bone. So we talk about PTJ, the prosthesis tissue junction. In a perfect world, the intaglio surface of our fixed detachable is going to be ovoid, nice and round, smooth, make it easy for the patient to get in and clean. In the maxilla, we can't do this because of those already mentioned phonetic issues, the spittle. Lower arch, the high water Brandemark design that we originally saw back in the 80s, we can still do that in the lower arch. Removable in the upper arch, fixed in the lower. To me, that's a great combination because we can make it off tissue, make it easy to clean. We can also have kind of a oval design here. This, when we get to the questionable area, this is the modified ridge lap, compression of anterior tissue with an opening. And this is what we call the lunch box because everything the patient eats is going to end up in there. How's the patient going to clean that? I mean, you think about these poor patients. Think if you were that person in your social group that when you came up to talk to somebody, everybody covered their mouth. Oh, here comes Richard again. Whew. It'd be embarrassing. I mean, they say that 90% of us wake up in the morning with halitosis. We can at least brush our teeth and get rid of it. These poor patients live with it. When we talk about acrylic, acrylic's porous. Acrylic needs to be jumped and replaced every 5 to 7 years. Think of it, we've all how many people have ground into a denture that's been in the mouth for 10, 20 years? Right before you, right? If it's bad for us to smell, think about that patient's, husband or wife, their kids. Mom's going to kiss their kids and their kids are, throwing up in their mouth. Let's help out our patients. We've seen way too many of these lately. How many folks have never seen a case like that in their laboratory? Way too many of these. Number 1 cause of this, not treatment planning correctly. Should never be done. So again, the ideal is a convex intaglio. Nice and rounded, easy to keep clean. Lower arch, piece of cake. This is in the maxilla. Again, tissue compression, we open it up. But again, this has to be somebody who has the dexterity and hygiene to clean. Because if they don't, even with the modified ridge lap, this isn't bad. We're going to get a lot worse, guys. There's a reason I'm on at 1 and not at before lunch. This will be fun. That's not bad. That's really not that bad. You could pull implants out. There was nothing, look at this design. It was modified ridge lap. The patient just didn't clean it. Okay, we won't get that bad. So a lot of you have probably seen this slide. I've shown this for at least a decade. Nobody took into account the lip line. This is at rest. So what was she provided? Was she given a denture or was she given a removable bridge? How many patients will pay $40,000, $20,000 for a denture? Nobody. How many will pay that for a removable bridge, right? You think about it, whether that removable bridge is a bar or whether it's 4 studs, same properties there. We have ponics, we have supporting areas. Hey, a removable bridge. Hers happened to be 4 seat attachments on a bar. Still functioning as of 3 years ago. She refuses to take a picture of it because, as she says, she looks old. all relative. So yeah, lip line was not taken into account. Patient dexterity. Now, again, this is one I saw in a lab slip. I've seen it twice in the last 6 months. I was excited because I don't see it on a lab slip at all. You know, I've talked to one of my buddies as a prosthodontist, and what he does is he holds out 2 fingers to the patient and says, squeeze my finger. And if they can't squeeze his 2 fingers enough to make it hurt a little bit, then he doesn't think they have the dexterity to clean a fixed case. I thought that was interesting. I used to have a slide of Darth Vader saying, pull my finger, but I kind of got tired of that one. So what about the implants if the patients don't clean them? We all know that if you have calculus and bacteria on the intaglio of the prosthesis, tissue doesn't grow towards it, it pulls away. What happens if we get that buildup on the implants? The bone is going to recede. So what happens here? You can see how much bone loss we have here. If these weren't splinted together, we'd probably lose it. You can see the same thing here. So when we uncover them, you can see the buildup. A lot of exposed. What do you do in a case like this? My recommendation, we take that patient to removable. And again, a case like this, I told you this isn't that bad. Adequate hygiene. This patient had this in the mouth for 3 years. She went to a prosthodontic practice in Arizona. You can see how much bone and tissue was lost in 3 years. When he removed it, the prosthesis, the implants came with it. So what did he do? He converted her. We'll skip by these real quick. Bone grafted, put more implants in. This was when the patient presented. You can see how much bone loss there is. But this is what he converted it over to. And you can see how much acrylic there is to make up for the lost bone and soft tissue. Let me see if this will work. I lied, Kate. I do have a video. So you saw how difficult it was to remove a stud with, 3 attachments on it. Probably not a good candidate for fixed, but that was the resolution there. So, all right, we've seen a lot of horror stories, a lot of contraindications for patients that shouldn't have it. Let's kind of go into treatment planning these. So what are our advantages? Stability. It feels natural for the patient. These are fixed teeth. This is what the patient wants. I don't think a lot of patients probably come into your client's practices and say, I want something that's going to move in my mouth. It's what they want. They want fixed. We're splinting our abutments by tying it together with our bars, whether it be zirconia, titanium, a high-performance polymer. We're maintaining bone, which is huge. Open palate. Patient can taste, hot and cold, and the aesthetics are phenomenal. We've already talked about the self-esteem now. The aesthetics we provide nowadays, I think, are just out of this world. I mean, one of the first things I do most mornings is I go onto Facebook just to look at the new cases I'm seeing posted. It's awesome to see the work out there. It's one of the reasons why I'm here instead of out there. When I was in school now, have you guys heard my story about me being in school yet? I was in lab school. How the instructor called my dad. Nobody's heard this? Oh, okay. I'm going to make fun of myself. This will be good. So I had A's in the class, but the instructor calls my dad up one day and he says, hey, what's Chris going to do when he's done? And he goes, well, I don't know. He really Anyway, that's a story about how I'm here instead of sitting there. What is it? Those that can't teach, something like that? That's me. All right. I got like 2 chuckles out of that, making fun of myself, and that's all I get? It's either post-dinner or I'm rusty from Zooming for the last 6 months. Yeah, exactly. I'm going to pull up my pants and pretend they're shorts. Getting dressed up for you guys, man. All right. Disadvantages. We need more and larger implants, fully implant supported. We already talked about we cannot independently service. Something goes wrong, we have to remove all the screws, the whole 9 yards. The hygiene aesthetics trade-off, that is that modified ridge lap. We're compressing tissue for aesthetics, but again, we're making it harder for the patient to clean. It's that trade-off. And again, that's where it comes in. What's the patient's age? What's their hygiene? What's their dexterity? What's the best thing for the patient? We know it's more expensive. Phonetic issues. We better not have flanges. That's more than unhygienic. Lip line, cheek biting, yeah. A lot of disadvantages, but the big thing is this is 90% of functional capacity. This is where we want to be. So material selection. A lot of the times we're going to go with the titanium structure, porcelain on it. We can cement individual crowns. It's strong, rigid. We've used porcelain and titanium for years. Drawbacks, porcelain fractures, and of course, screw loosening. All right, kind of common sense there. Now, zirconia is biocompatible. Bacteria doesn't stick to it. It's polished nice and smooth. High strength. Now, what happens if something snaps and it breaks? With a titanium structure, we can weld it back together. We can fix it. Zirconia, what do we call it when it snaps? A remake. Exactly. Porcelain fracture chipping. Now, we don't see that as much anymore because we've learned over the years how to prep for putting porcelain on zirconia. It's not the same as it was for PFMs. It's a little bit different, the prep. Now, this is a discussion that comes up a lot. It's not kind to the opposing dietitian. I've read a ton of reports in the Journal of Pros about zirconia wearing natural teeth. I've also read the same number of reports about highly polished zirconia not wearing opposing teeth. I think there's a fine line in there. I'm not a zirconia expert. I think it's inconclusive, but if I was going to highly polish it, I would feel comfortable against the opposing dentition. My concern with zirconia is there's no shock absorption. None at all. So if you've got zirconia against zirconia on implants, again, no proprioception, no periodontal ligament, there's no give. The patient's exerting a huge bite force. So what's going to give if the patient overloads the prosthesis? What's going to break? The bone, the zirconia, the screw? Hopefully the screw. The zirconia is going to break. Flexural strength is different than flexing. Flexural strength means it's not going to break. Something is going to break besides the zirconia. Your implant abutment, your implant, or your screw. So one of my buddies, he is a huge proponent of zirconia against zirconia. He also has a ton more clinical experience because he's head of the pros department at UConn. His theory is that the TMJ is your give. My theory is that the patient is still going to overload it. I was always taught rigid against resilient. And even if we want to have 2 fixed cases, I'd still rather have one be acrylic on a titanium bar because we know that denture teeth are a fail-safe. If we overload, the denture teeth will debond. That acrylic will shear. That'll stop the patient from overloading and breaking something worse. So that's my 2 cents, and we'll get into that a little bit more. All right, so this was a study done on zirconia, basically saying 99% survive. A couple tie bases debonded because we know when tie bases came out, they were all made too short. 4 or 5 millimeters is not enough to support these loads. Guilty as charged, absolutely. So let's talk about acrylic. We've already talked about acrylic. We need to replace it 5 to 7 years. That's a major, I would say that's a negative of this compared to zirconia. But how many of our clinicians or how many of us are helping our clinicians, and when they're presenting these cases, are we telling the patients, you need to come back in 5 to 7 years because you know what? The teeth will be worn down a little bit and they'll be yellowed a little bit and your acrylic won't look as pretty. You know what we're going to do? We're going to give you all fresh new teeth and acrylic and make you look great again. It's part of the servicing. How many folks do that? We're used to buying new tires, right? Tires don't last us forever. Why should we think something in the mouth is going to last us forever? It's not a lifetime warranty on these. 5 to 7 years. If I'm a patient and I'm told up front when I'm getting my prosthesis delivered, hey, in 5 to 7 years, I need to come back and I'm going to have straight white teeth, or maybe they'll be characterized for my age, but my dentist wants to make me look good. The restorative team cares about my health. Awesome. I'll pay that $2,500, that $5,000 to every 7 years to look good. Let's work with our clinicians on that. Absolutely. So, of course, more prone to breakage and servicing, metal and acrylic. Maybe that's good. It's a fail-safe. All right. So then we get into high-performance polymers. And this has really been interesting. We've seen a ton of these. The whole idea here is that these have the same modulus of elasticity as bone. They're going to flex just like bone does. We know the mandible flexes under load. These are going to flex and protect your implants. These are going to divert the force from the implants over a wider surface area. So this is why these 3 types of high-performance polymers have had great success. Most of them had good bonding. Trilar in particular, because it is PMMA-based, is great with your acrylics and composites. I was concerned, honestly, about the peaks and the pectons, about the bonding properties at first, because inherently they don't have the chemical properties to bond your veneering materials. There's a lot of ways you can finish them and prime them to get great bonds, and they've had great success. What we don't have is a 5-year track record. But I think these materials, they're more cost-effective in general, and I think they're lighter and kinder to the patient. This is a great option as we go forward. And most of the time, if you're milling these in your laboratory, it's the same strategy as PMMA. So, let's see here. This was an interesting study down at the Malo Clinic. Most folks familiar with the Malo Clinic down in Brazil? They were the ones that invented the all-on-4 technique, Paulo Malo. One of the most interesting discussions I saw in the last decade, it was 2 microphones up on a stage. One was Paulo Malo, and one was the godfather of implant dentistry, Carl Misch. And they have 2 completely different mindsets. Paulo Malo is, give me 4 implants, I will load anybody. And of course, Dr. Misch, he was going to graft, he was going to place 6-8 implants. I mean, he was going to make this bulletproof case. I mean, he probably had less failures than anybody. He was an engineer at heart. Beautiful work. And the 2 of them were on the same stage, and it was really, really interesting to see the 2 different clinical approaches to it. Both of them work, but Paulo Malo's clinic down in Brazil converted over to a high-performance polymer recently, and their study results were really interesting. That, when we're talking about 98% versus 100%, they both work. But when we talk about peri-implant disease going from 3% down to 0.5%, marginal bone loss being cut in a quarter, I mean, these are some pretty impressive numbers. So, maybe we are getting the clinical data where the high-performance polymers are the route we go in the future. Questions, comments? Anybody want to disagree? Please go right ahead. Still good? All right. So take a couple minutes and go through a couple of the workflows. And this is going to be all about the foundation. Wax said, I've been trying. To me, this has been the #1 improvement since we've gone to digital versus analog. Back when let's say we're doing RPDs. Back when we're doing analog RPDs, I can't tell you how many times I got a phone call from the removable lab saying, why the heck did my Crown and Bridge lab place this fill in the attachment? ERA, SICA, 5 millimeters off tissue. Well, did you give them a 2 setup, your verified cast? Well, no. Well, you didn't know where to set it. Why is the hater bar 8 millimeters tall? Well, did you give them the tooth setup? At least now we're starting with our tooth setup and we're designing the structure to support it. I think there's a lot of flashy names now. I think one I've heard bandied about is start with the end in mind. It's been the best part for me of digital because now I'm not getting those phone calls anymore. It's fantastic. I get 2 different phone calls I don't like, and we'll talk about those. But, you know, we got our wax set up and trying. From our clinician's point of view, number 1, the patient's approving the mold and the shade of tooth. The significant other's approving it. The worst case is we get done with a beautiful, beautiful restoration, and you know the patient goes out to dinner with some friends, and her friend looks at her and says, "I don't like your new teeth." It's a remake, isn't it? Make sure the patient approves, a significant other. When we talk about a verification jig, and this has been beaten to death, but apparently not enough yet, use metal parts. You can use an open tray coping. You can use a verification cylinder, non-engaging. Eugene, how many folks here saw Eugene at 10 o'clock this morning? Eugene is one of my really good buddies, and he's also one of the cheapest guys I know. And I say that with love because he is. He admits it. So he's shown this case a number of times. I don't know if he talked about it, where his doc sent him engaging cylinders, and he wanted to use them. So he just ground off the engaging part and he used them. Okay, great. Then he put them into his plaster setup, and he broke them out. He made a plaster verification jig and then broke them out because he wanted to reuse them in the provisional. Well, what happened to the provisional? The cast broke when he was making it. Could he put the cast back together? No, because he took the impression copings or the jigs out of his. He took the temp cylinders out of his verification jig, so he couldn't reassemble it. So anyway, it was fun. Eugene and I learned a lot when we were working together on that case. Anyway, you might think it's funny. We had this come in 2 weeks ago. Somebody wanted us to make a bar for them, and they used plastic UCLAs as their verification cylinders. Plastic. No way. No way. So let's talk about, we've all got our techniques for verification jig. I'm happy to go by these in about 2 seconds. Does anybody have questions on verification jigs? The way I presented that, nobody's going to raise their hand, even if they do, are they? All right. 2 techniques. A solid block. We open up a window so we can make sure, visually see that they're seated. An x-ray's taken. Sheffield 1 screw test, one at a time, back to front. See if there's any rise, if there's any flexure. If not, we're in business. Alternative number 2, you section your jig before sending it to your dentist. You number it so they know where to place it in the mouth. Make it easy for your dentist. That's one of the biggest things we can do as technicians is make it easy for our dentist. If their chairside time is $500-$600 an hour, let's not make them spend 10 minutes trying to put these in order. Put them in number. It's one of the things like when we talk about studs, you talk about a locator case. Why, if our dentist wants to do a chairside pickup, why aren't we processing with the Delrin spacers? What do the Delrin spacers do? It eliminates the 10-15 minutes your dentist needs to go chairside. Put the housings on with indicating paste, hollow grind out the inside of the denture to give the vertical and diameter they need to pick up the housings. Processing spacers, they're Delrin, they pull right out of the acrylic. It's pre-relief for your dentist. Save them time. Most of the time I tell you to raise your prices. I'm not going to do that today. Instead, I'm going to say if you can save your dentist 5 to 10 minutes per appointment, and you can show him or her that, then you can raise your prices. How's that? All right. So one technique I want to show, and this is for zirconia. This was from a technician friend of mine that at one point had probably done as many zirconia cases as anybody. He's moved away from it, but this was his technique right here. This is Bill's technique. Primary impression, he would have a verification jig sectioned. He would have his dentist lute it together and pick it up. So luted together, picked up in a new impression. He'd pour up his new master cast. He'd make an open tray on his master cast, but he'd make it out of stone. The stone is an old technique, but it's fantastic because if it's not 100% passive, what happens with stone? It snaps. And you'd rather have that extra appointment of your stone snap than your zirconia snap. So if this stone jig seats passively, then we know the zirconia will seat passively and will eliminate that fracture. Now, when this goes in the mouth, it's the same Sheffield 1 screw test technique. What happens if you get that fracture? Well, the same thing we would do with a regular, resin verification jig. We're going to lute it back together, pick it up again in a new impression, pour up a new master cast, and go through the technique again. It might take an extra patient visit. It might be a couple $100, but I tell you what, for the cost of the full art zirconia structures, and even more so, the patient's loss of confidence in the restorative team. We deliver something to the patient that they love and tell their friends about. That's the number one way we can help our dentists get clients. We provide something that breaks, that fractures, that doesn't meet expectations. That's not that 5-star Yelp review. You're not getting the extended family. You're not getting the whole church group, the whole bridge group. You're limited. So lute it together, pick it up, new impression. Oops. All right, so questions, comments? All right, 2 different designs for our fixed detachables. This is the wraparound design, meaning that we're wrapping acrylic all the way around our implant superstructure. And again, superstructures could be titanium, it could be high performance polymer. This could be any material. Pros and cons for this. Pros, well, as the patient's anatomy changes, if they lose soft tissue, if they're losing bone, we can treat this like a denture. We can add more acrylic and basically reline it to establish tissue contact. We can service this case right here. We can service the intaglio area. The con, well, it takes more space because of this, instead of this being titanium to tissue contact, we need more space for acrylic. We also need to learn how to support it with different mechanical retentions. Otherwise, it will shear off. So again, this is ideal in the maxilla because we can shape our acrylic in a certain way. We can open it up a little bit easier, but again, it takes more space. So we take a look at how much space, minimum of 14 millimeters of vertical. So this was one of the early milled bar designs. I actually designed this one right here. I thought it was really good. Lots of nail heads and struts coming off, the buccal surface. And I'm like, great, nothing's going to shear off. It still did. So, you can see here, even when the bar is sandblasted, it's primered, you can see this was definitely prepped. The acrylic and tooth snapped right off. Another problem, and this was some beautiful gold work, fracture. Oh, there's so many pictures like this. And a fracture. So I think there's a solution to this. There's 2 solutions. One is the high performance polymers. The other is printing. So printing of bars has a definite advantage over milled. Number 1 is you can have the surface retention different. Number 2, has anybody here ever ground into titanium? Does it get easier the longer you grind or harder? It gets harder. The more you grind into it, the harder it gets. So when you're getting a bar milled, most of the time it's a softer grade of titanium because you don't want to go through 4 or 5 burrs to mill a bar. So you're using a grade 4, a grade 6, maybe a grade 5 titanium. The printed alloy is a grade 23. It's 50% stronger. What that means is you have a stronger, lighter restoration. Maybe if you're fighting for vertical space, you don't need to have connectors this big, but this is definitely an advantage. So we talk about printing. This is what printing looks like. This is selective laser melting. It's a plate just like a piece of paper. This is, I think it has about a dozen frames on it. So you'll see the arm come over, drop down a powdered layer of titanium. The laser goes around and the laser melts the powder and it starts building it up layer by layer. Now this will happen thousands of times. This is super slow motion. Another big advantage of printing because you're not relying upon the puck size. If you've got somebody that was had a shotgun wound. We have lots of those. A cancer patient, somebody like that lost bone. You can have that 18, that 24 millimeter tall structure. Because with printing, it takes longer, but basically you're not limited by the size of the puck. So, works good. And of course, milling is accurate, works well, but we know we can't get into undercuts. We know the material is not as strong, but this is super accurate and works well. So, these are just a couple examples of printing. I won't spend a lot of time here. If you want to see printed bars, come by the booth. We got a whole bunch out there. I just love the mechanical retentions. All right. So, second one, we're going to call a Montreal bar. Basically, the whole idea here, as opposed to a wraparound, we're going to have a metal intaglio surface. It's more hygienic. Biomechanically, trade-off, we have to, in the anterior maxilla, we have to have a facial tilt here to get that compression of tissue. If the patient loses any bone or tissue, we can't add acrylic to this. So what does that mean we're doing? We have to remake it. So this is the trade-off. But again, this is much more hygienic. Titanium is much more, works better with tissue than acrylic does. This is nicer for the patient to keep clean. So again, pick your patients wisely on this. This has been more popular. These are some of the bar designs from a few years ago. These are actual cases. Biggest complaint I have about this case is you can see the concavity here, the lunchbox design, impossible to keep clean. And one of the trade-offs, again, is how much space it takes. So this is really engineered well for being milled. You can see how it's got all the different nail heads and struts and a nice finish line, support area, but there's really not a lot of space. So this is where, again, printing comes in. I'm gonna shoot by this one, get some good ones. This is kind of cool. We call this the banana slug case. Polished lingual, intaglio surface, and the mechanical retention for your veneering material. Again, I'm not gonna spend a ton of time on the bars. This was a comparison of a milled to a printed bar for mechanical retention. And then to me, I want to spend a minute on what I think is the best design right now. I'm gonna shoot by this. Okay, 1 second. Big trend nowadays we're seeing is either the last tooth left in titanium or cobalt chrome, or having a zirconia crown cemented there. And why is that? Whoever answers this gets a free cuff-ite tool. How's that? If you don't know what that is, I'll show you. Why do we want to leave the last tooth either in metal, zirconia, instead of having a denture tooth? What does a denture tooth do over time? Is this tooth going to wear down? This is going to maintain the vertical dimensions, right? I led you on that one. Okay, whoever said that. Who said that? All right, you win. All right. So I'm going to shoot by this one real quick. Okay, we're going to get to it now. Here we go. To me, this right here is my favorite design of all the bar structures I've seen right now. This to me has a beautiful finish line of mechanical retention right here. This is a great ledge for mechanical retention for your denture teeth or your, whatever material you're using. We know the bite forces are greater there. You can see here where we have that ledge. This is going to be like Velcro holding in your veneering material. The finish line, access channels. Again, that ledge. To me, this is the best of both worlds for the patient. This is going to be nice and hygienic for the patient to run their tongue on. It's going to be highly aesthetic. It just gives you the best of both worlds. So I love the design like this. We have a couple of those sitting at the booth. Kind of older school design. So when these get done, when we're done with these, we're like kind of kids at Christmas. So it's hard for me not to throw in a whole bunch of bar designs. We'll shoot by these. All right. Oh, this is a good question. Let's take a survey. This is audience participation. So do me a favor and raise your hand. If you don't raise your hand, then you lose your cuff-ite tool. All right. How many folks here want nail heads on their bar? Raise their hand. 1, 2. You're losing your tool, dude. How many people don't want nail heads on their bar? All right. You can keep it this time, even though it's like 50%. Technicians never retire. You know that. So again, it's another interesting debate. I think these take, this is just my opinion, I could be wrong, disagree with me, but it looks like the group kind of agrees. I think these take up valuable restorative space. I'd rather have a thick block of acrylic and a full denture tooth rather than have this coming into and reducing my acrylic and denture tooth. That's my 2 cents. Now, and if you have the vertical, yeah, good point. Metal occlusal, again, this comes into our treatment planning. Does the patient brux? Do they grind? If the patient bruxes and grinds, do we want to make it metal occlusal, or do we want to make it denture teeth they can wear down and we can replace? Again, the restorative team can talk about that. What's best for the patient, what's opposing. So this is a case I like to show. This was one of the first bars I did. It's a beautiful picture. It's a beautiful bar. But what did I really mess up on? Is this going to be easy for the patient to clean? I followed the gingival anatomy instead of sculpturing it the way I should have. I should have made a nice convex surface and made it easier to clean. I redid this case. Absolutely. It was an expensive learning experience, but you know, after that, and one of the nice things is when you're working in a lot of the CAD softwares, like ExoCAD, for instance, you can ditch your die. So you can ditch it, let's say 0.5 millimeter, so you can get that tissue compression when it's seated. You can make that nice convex design, that ovate ponic. The patient can withstand 5 millimeters of tissue blanching. 0.5. Did I say 5? I meant 0.5. Wow. Yeah, that'd be a little bit too much. All right. And this is something we're seeing quite a bit nowadays too, to make it easier for the clinicians, having the access channels easy to see coming through the veneering material. Now take a look at this one right here. This worries me a little bit. In the corner, you can see how it looks like kind of like fangs. You know, something you see in a Halloween costume. I'd be worried about that little tooth breaking off. That's kind of sharp, but this clinician didn't want to spend time digging, looking for access channels. They're right there for them. Individual preps, that's something we're seeing done a ton, especially with zirconia and the different materials like that. So more individual preps. Okay, that's where it gets fun. How many of you cell phones have, I can't even speak English. How many folks your cell phones have about 80% teeth pictures on them? My screensaver for a couple months back in the day when you could like socialize was this. And I left it out at a barbecue one time and it kept on ringing and people are looking at it going, oh my God, that's nasty. I think this is cool. This is so cool. This is an everyday case that comes into our laboratories. We know that the facial bone, the maxillary facial bone is flared out. We know the implants are going to be placed this way. We know the access channels are going to come out through the facial aspect of our teeth. So what's really nice about that, you take a look at your options. Hey, we can have a different color little dot on the teeth. All right. We can do our best, right? Make it work. Okay. Yeah, another one. You can see this shotgun looking, gunner tank right here. So what do we do on a case like this? We made a primary bar, little tiny primary bar right here. You can see the little rest seats. And then made a secondary that still engaged these 4 implants. Almost a keyway was designed right here. So when it engaged, we had our 4 vertical screw access channels and 1 lingual set screw. So that's how we got through that one. So again, what are our prosthetic options when we have implants like that? We can use cement. I think we've all read way too many articles, seen too many cases where, cement gets down beneath the tissue, bone loss, etc., peri-implantitis. So what are our options here? I mean, this was from the 2019 LMT. This was really telling. If you take a look what's happened in the market just in 3 years, we've gone from 42 to 64% of dentists prefer screw retained. That's a huge jump. We've gone to the 36% of dentists want cement. So if we can provide screw retained to our dentist, on most cases, that would be another way we could help our dentists and save them time. So when we talk about cement, one of the things we need to take in mind, this was an article in Journal of Pros. It was talking about platform switching, which is really popular nowadays because ideally we're going to maintain bone more with platform switching. It's going to be more aesthetic. We're maintaining our soft tissue, our emergence profile. But there's a little bit of an undercut here, right? So if we have a cement leak, this becomes an undercut that we can't see and is impossible to clean. So this article is saying that when we do have a platform switched abutment, it needs to be screw retained instead of cement retained. And again, they went on to say greater flexibility. Now with angled screw channels, we can come in the anterior maxilla without grafting, without cement, provide a restoration. Whole way this works. How many folks here have worked on an angled screw channel case? 1, 2, 3, 4, 5. You said you're retired. I'm not listening to you anymore. All right, so here's the trade-off. Normal screw access channel, small hole. Because the driver has to pivot inside the access channel, it's about double the size of a regular screw channel. So again, we ask ourselves, what's our trade-off? Are we weakening our crown? Are we weakening our bridge, our structure, by making this big access channel? So again, another study of Journal Pros loaded up 30 with screw access channels, 30 without that were cement retained. Their final results, no significant difference were found in fatigue, fracture resistance, and access channels that had nothing to do with, didn't change fracture resistance. So, all right, that theory's out the window. Everybody still good? All right, good. Good. We'll be done in no time. Those of you that know me know I could probably sit up here for 2 more hours, but I'm not going to do that today. All right. I timed it. We're going to be short. So another thing that comes with screw access channels we're worried about is what happens if you strip the screw? This is a question that comes up all the time. Is what happens if you strip the screw? Because you can't go straight down. You're coming at an angle. I got 2 solutions for you, but the way this driver is tested is if you get to the point where you're going to overload the screw and strip it, the driver is going to snap. You try and take that above 50, it snaps. Now, the other way, if let's say you did strip the screw, this is going to sound crazy. You take one of those kind of, they look like fettuccine noodles, like the rubber bands that are thicker. You take one of those and cut it, put it around your driver, take a soldering tip and kind of melt it together, and push that down into that stripped screw. The rubber band fills the voids of the strip screw, and you can get enough friction to back it out. Of course, you can still do the slotted screw, but those rubber bands are great for that.
Does that work on the implant screw?
Yeah.
I saw that online. They do it like regular screws.
Yeah.
Really?
Yep. So that's another way you can do it. So this was a case a couple of years ago when we first started beta testing the angle screw channels. This was at University of West Virginia, the Pros department. Patient had this for 3 years. They were on Straumann tissue level implants. Now, who here can tell me why that's significant Straumann tissue level? They don't have angled multi-units. Dude, thank you. That was awesome. They don't have angled multi-units. They have straight ones. So what does that mean? We can't move the access channels. So this patient, again, they had this for 3 years. They'd gone through 2 residents who had this case, and the last resident made veneers out of composite to try and cover the access channels. And of course, when the patient functioned, they kept breaking. And they looked weird and the patient wasn't happy. So we were involved in the case, trying to the new denture, trying to the printed bar, opaque, ready to process. All we did here is we moved the screw channels 30 degrees, just using the driver and screw that pivots. Before, after. This was the ACP Poster Award winner, I think in 2016 or 17. And it was beautiful work. I think there was about 13 or 15 slides. And I told him, I said, all you need is this. Before, after, you win. I mean, think what a change this is for the patient. Here they're worried about showing a different color and chippage when they're out. Here, these three move back, life is good. Before and after. So again, the way it works, you have a driver that pivots inside the screw, rotates, you can come at different, yes sir. Sure. Common was sometimes on cases like that, you can do telescopes in the anterior, screw retained in the posterior. I'll show you a case later that almost the exact thing was done. That's a great solution. Yep. The other thing that's unique about the angle screw channels, and this comes into play when you're working with one of the systems that doesn't have the 12 or the 8 or the 6 faces, let's say the Nobel trilobes, you've got 3 indexing points. And if you want to move the screw channel, you're kind of tied to those 3 points. What's nice here is you can go 45 degrees from this cut to this cut to still compensate for those limited areas of indexing you have. So again, when we talk about those indexing areas, a lot of the times you want your oral surgeons to have one of those lobes pointed to the lingual, knowing that you can engage your abutment there and rotate it back. But if the oral surgeon doesn't point one of the lobes there, that's where having a system that can pivot 45 degrees can help, restore the case. So this was the final patient right here with their new teeth. Another case, screw access channel was way off here. So this is where we combined that 30-degree multi-unit with the 30-degree of angle correction. 60 degrees we moved right here. Now the beauty of this is we're not off-axis loading 60 degrees. It's just the same as the 30 degrees with the multi-unit. We're just moving the access channel an extra 30. So as you can see here, we moved the access channel back from where it was here to here with the multi-unit, here with the access channel. I know that's some pretty poor Photoshop work, but I'm gonna blame Ruben's not here. That's Ruben's fault. No, I did that. So this is after it's moved. All right, and different heights. So, do I have your permission to share something new that's coming, and that it doesn't leave this room because we've worked on this for like a couple of years. All right, I'm going to show you anyway. All right, so traveling all the time, one of the things we do is ask, hey, what are some of the problems you run into? What are some of the issues? And what we heard a lot was, well, if my dentist uses fill-in-the-blank scan body, I'm tied to only using fill-in-the-blank tie base. It's a 1-to-1. You have no restorative selections. You have no choices. So, something like this, I call this the no-choice system. If your dentist uses a fill-in-the-blank, whatever scan body, you have to use the same tie base, right? So, you're messing up my sales pitch, dude. No, I'm sorry, go ahead. If we're talking about digital workflow from a scan body, yeah. You're right, but then you're not using the scan body. You're hand prepping it, an analog, yeah. This is straight with digital. So you prep it, then you scan it. Okay, so you scan it as a button and bring it in. Sure, I hear what you're saying. All right, you and I are talking apples and oranges, but I get what you're saying, and it's a great solution. So what I'm talking about is a scan body that your dentist is scanning in the mouth and sending to you. I'm not talking about prepping an abutment. We okay? Okay, cool. I'm gonna give you the mic though in a minute. So, picture time. So here's the whole idea here. You have one scan body. This is what people have been asking for, and you nailed it right back there. You said the tie bases are all too small. When us as manufacturers first came out with them, 6 millimeters was the tallest we made them. That was an error. 975 out of one scan body. Oh, then there's a regular 6 millimeter tie base out of that scan body. You know what though? We really need one that's 12 millimeters tall too. And if you want, you can cut this down. And this is really skinny also. This is great for anterior teeth. But better yet, what if you had 3 other options? What if you had temp cylinders in there at 3 different heights? Why do temp cylinders matter? You want to print out a quick provisional. You're doing an all-in-4 conversion, and you want to print out the denture ahead of time based on the cone beam scan. You can have your temp cylinders, open up your cement gap a little bit, so where you don't have to trough out the existing denture. Boom, you've got your denture printed. You take it to the mouth for the conversion, and you've got a little tiny area where a dentist just has to lute in a little material, light cure, and you're done. So all of a sudden, out of one scan body, intraoral scan body, your dentist scans it, sends it to you. You can send back provisionals, finals. You have 8 solutions. And if we take a look at fixture level, this is just multi-unit. If we take a look at fixture level, engaging and non-engaging, all of a sudden you got 16 choices. So the marketing people call this the choice system, but this is something that Ruben in particular, I wish he was here because I give him the credit. I told him I wanted to do something like this, and he's been the horsepower behind it. He's done a great job on this. We've had a ton of beta testing. This will be launched next month. So again, out of one scan body that your dentist intraoral places in there, scans it, sends it to you, you're not tied to one solution. You can have your angled access channels. You can have your straight, you can have your skinny, you can have your temp cylinders. You can have everything all in one library. So that's something we've been excited about. Is it something that we're gonna, become giant rich people off of? No, but I tell you what, it's gonna be a great solution for I think everybody sitting here. It's gonna make your life a lot easier and give you choices. So, yes, sir. Yes. Yes. Yeah. So great question. The question, and I'll clarify that because I didn't do a good job there. Question was, would it make more sense to have one piece that you could cut down, rather than all the extra inventory? That's exactly what it is. So you have one of these and you can cut it down to whatever height you want, and it's in the library already at the different heights. One of these and you can cut it down and it's already in the library that way. So yeah, you don't have to stock all this stuff. Not at all. Thank you. Yeah. All right. So this would kind of be the workflow. This could be, the scan that's done either in the laboratory or by your dentist, any of the iOS systems. Once it comes in, of course, we want the 2 setup. We're choosing different abutment options based off where the access channels are coming out, as well as the height we have inside the prosthesis. After we move the prosthesis, we can see there's a couple we're going to move the access channel. And again, when we first came out with the angled access channels, we've had 5 years of beta testing on this. I thought it was all going to be anterior maxilla. And it's funny, at least half the cases are posterior teeth. And again, why do we do that? Because we want to raise our prices by saving our dentists time. If we can move the access channel to the lingual to make it easier for our dentist to retrieve a crown, and we save 5 minutes of time, that's great. We're doing a service for the patient and our dentist client. So we see a ton of posterior angle access channels. Again, different heights based off of how much space we have. Back inside our prosthesis, we can see, hey, that's a little tall. Let's go with a shorter option. Don't you yawn. I'm excited by this, so no yawning. And again, you know, your model flow has your analogs, everything ready to go. And here's how we're going to design our final Zirconia, bridge, PMMA, whatever we happen to be using. So anyway, I think this is exciting. I'm going to skip the video. All right, there's 2 other options I want to show you. 3 other. Are we good for 3 more? Yeah, 15 minutes, 3 options. Okay, cool. So I'm going to shoot by these case pictures real quick, just showing the pivoting, how much space saving it is. All right, one comment on this one. This was really interesting because on this case, we only needed 3 of the angled access channels moved. It was 6 implants. And they used all 6 with the angled access channels. And I said, why? As Bill, I said, why did you use all 6? And he said, because I want to save my dentist time. I don't want them switching out drivers. I don't want them switching out drivers when the patient is over. I only want them to have 1 screw. I want to make it easy. And I was like, okay, that makes sense. The other time we use angled access channels, and this is kind of great. This is a milled bar. You can see if we had brought the access channel straight, it would have basically run into this. These 2 implants are so close. We tilted this one 30 degrees, and we tilted this one, you can't really see from this angle, to the lingual 10 degrees to open up more thickness of bar between the 2 channels. All right, so just a couple slides, 30 degrees. And the posterior tilt, we see that a ton. Zirconia, moving the access channels, and again, this is beautiful work. I could never do anything like this. The final. So nice, simple, no access channels showing, all through the pink. All right, one more case because I like this one. So this is showing with 3 straight screwdrivers. Once we tilted it with the angled access channels, the screwdrivers, boom. We took it out of the facial aspect. It's been in the mouth for a couple months now. No problem. Yes? 30 degrees is max. Now, you actually can go 45. 2 things about 45. It's not FDA approved yet. 30 seems to be the magic number with the FDA. And if you go 45, you're opening up such a huge window from the lingual. You know, even though I showed that Journal of Pros report about, you know, the access channels not weakening the structure, the 45 makes me really concerned. It's a giant window. Yeah. I mean, if you want to put like an angled abutment, like a multi-unit on there and then do 30 degrees, you can get your 60. But again, if we're talking about a single tooth, yeah, I'm not going to put that on a non-engaging multi. So it's maybe, yeah, it's a trade-off. All right, so this is one of the 2 things I want to show you before we kind of wrap it up. I love fixed cases, but people often ask, and I'm sure I'm not the only one in here, what would you put in your mom's mouth? To me, I want something that she can clean, that gives her confidence, that doesn't move, that can restore lip contours. I want something that can do all of that. And you're like, yeah, well, that's both fixed and removable. What's a combination of them? And this is where, you know, I like that. That was good. That's my son. Who asked if that's my mom? This is good. At least we're waking up now. I like this. Cool. All right. That was my little boy. All right, so I call these a fixed removable. This could be a removable bridge. To me, this is the absolute best restoration we could provide. Feels fixed. We're splinting abutments, maintains bone, open palate, stability. Oh, wait, we can have a flange. We can restore lip lines. All of a sudden, everybody's like, wow, okay, what's this now? Wait, the patient can remove it at night? They can clean it? It's easy to clean. We're not worried about hygiene, dexterity. Wow. All right, what's the disadvantage? More expensive. That's the disadvantage. So what is this silver bullet I'm talking about? We can take a look at something that's a primary, secondary. We can take a look at a bar that is fully implant retained and supported, but it doesn't move, depending upon which attachments we use. I don't want this to move. I'm a big fan of locators, but locators on a bar are resilient. I don't want that movement. I'm not going to put a locator on top also because it requires 15 millimeters of vertical. I'm going to put a plunger right here. The plungers are designed to stop liftoff. It's for patient security. They stop that movement. And if I use something like a hater clip in the anterior, keeping in mind on a bar like this, a plastic hater clip only rotates. It doesn't move vertically. So once you get 2 to 3 bar sections, you don't get rotation anyway. Hater clips can only rotate around a straight bar section. So if I've got a hater bar up front or a hater clip up front, a couple plungers in the back, the patient seats the prosthesis, you get the audible click, the comfort of incising over the plastic clip, the plungers engage the bar, it's not moving. To me, that's simple, it's low profile, it doesn't take a lot of space. To me, this is what I would provide most patients. Now, if I really wanted to make it interesting, I would make it almost like a Marius bridge, and I'd tilt the inclination out towards the facial, let's say 15, 20 degrees, to reduce any of the possible vertical movement. That's very easy to do in the software nowadays. A couple of the design principles for this is not compressing tissue. This is off tissue. My mom can get in here and clean this really easy. She has arthritis. She's got lots of aches and pains. This is easy to get in and clean. I'm not asking her to go with super floss, multiple times a day. She can go with a toothbrush and clean this. Another principle, I've made this round and smooth. I haven't made sharp angles. It's one of the things we see so much out of all the CAD bars that are designed. You see right angles, right? When we used to do wax and cast bars, did we make right angles on everything? No. If you think about it, if we're making a secondary frame on something with a right angle, we created a path of insertion. But if we round the occlusal aspect, all of a sudden it makes it easier for the patient to rotate it into place. Just like if we take a look at the gingival aspect, if we round that, that's easy to keep clean. So I want to make this nice and smooth and easy to keep clean. Now, of course, you can do different designs. You can put, metal occlusion. You can have different retainers. But one of the things we've done over the years, and this is a hater bar and locator case, split bar. I want to stop on this one. When we're designing a case like this, we're designing for something to fail. So on this case, it's got 4 hater clips, but we have 2 plungers. And I learned this from a friend of mine in Arizona. His name's Dr. Mark Montana, super bright prosthodontist. What he does when he processes this case, he processes all 4 hater clips into the prosthesis. He also processes both plungers in. Now that's overkill right off the bat, right? But what he does is he pulls the nail heads, and I'm going to go back here real quick so we can take a look at the plunger. He pulls the nail heads out of the plunger so that he just leaves the housing inside the buccal flange of the acrylic. Fills it with silicone or gingifast, material like that, seals it up. Why does he do it that way? Well, because if something goes wrong, if the patient has worn down the bar, and we all know the average edentulous patient, we all don't know, the average edentulous patient that goes to Clear Choice hasn't seen a dentist in 8.5 years. When we're designing these, the patients aren't going to come back every 6 months for servicing. So what he's saying is that if this patient shows up and the hater clips are worn out, they're broken, the bar's broken, it takes him about 5-10 minutes to open it up, put the plunger tip back in, boom, he's got a new attachment engaged, it's ready to go. He does the same thing. He does locators and also hater clips on the same bar. He processes all the housings in there. So if he needs to, he just pushes in the inserts when the patient comes back. Plan on it failing. So I kind of love, whatever attachments we're using, wherever you buy them from, plan to fail. All right. Questions, comments? Locator FTX. This is one of the 2 last things. Has anybody done one of these yet? All right, so I've been chairside on 3 of these cases now. I'll tell you the pro and the con for it. One of the big cons right off the bat, the word locator's in it. This is fixed. This is supposed to be a screw retained option. But everybody hears the word locator and they think it's removable, right? I mean, we get calls from dentists all the time. Hey, I have a locator O-ring. I have a locator ball attachment. Well, it's become Coca-Cola. It's become that brand, that everybody calls an attachment. So the whole idea here, this peak ball, and this green one in particular, has 20 pounds of retention, engages. There is no movement whatsoever. The load is 100% metal to metal. The housing sits on the abutment. The abutment is cylindrical, so you can rotate the housing around until you get into a parallel position up to 20 degrees. Does anybody want to watch the video? One. Actually, it's better than hearing me talk. Go for it. Yeah. So when you're measuring tissue cuff height, if you do an FTX, you can always round down, where with a regular removable locator, you need to go up. If you measure 1.5, you're ordering a 2 millimeter cuff height. With this, you measure 1.5. You can go with the 1 millimeter. Because this is fixed, it's not removable. We can blanch the tissue, it will adapt that 0.5 millimeter. So you can see here when the housings are going on, you can rotate those and pivot them around to get them parallel. Now we're going to do the chairside pickup. Transition that over to the denture, see where we need to relieve. The one thing I don't agree with here, I would always recommend cutting a lingual escape vent when we're doing a chairside pickup. As mentioned, there's 2 calls we get that are miserable. That is one, when something removable becomes fixed because it's locked in. And the second one is if a verification jig was not used on a bar and the bar fits the cast but does not fit in the mouth. And it is very uncomfortable telling the dentist that you just bought it. So just like regular locator, black processing inserts are used. Filling in the voids from the pickup. Rest of the conversion, removing the pallet, remove the flanges, pull out the black inserts, and put in the final retention colors. So I'm going to skip by that. So contraindications, this is the same as screw retain, but there's a couple differences. The maximum cantilever is 10 millimeters. It's a 1-to-1 AP. So if you have an AP spread of 8, you can't go back 12. You can only go back 8. Second thing is these do not go on multi-units yet. They have to go to fixture level. So that means if you have a dentist that's used, or oral surgeon that's used to placing implants on an all-on-4 where they're tilting at 30, you need to tell them to bring them back to 17. Again, it's going to reduce your AP spread, but simply if we go 30 degrees using a locator FTX, we won't have draw. It won't work. So shorter cantilever, you have to work with your oral surgeon to have the surgery done right. And then the third issue is you have to make sure you can seat it. Seating these are really hard. It can be really difficult. Again, the housings rotate around the spherical abutment. Talked about cuff height, different retention inserts. You're always pretty much going to use the green. This is an issue we ran into. You saw how the housings can rotate around the abutments. Well, the impression coping can also rotate around the abutment. If your clinician doesn't line up the impression coping spot on, let's say they take an impression and it's off a little bit, This is what the analog looks like. It's got a lip right here. There's no way you're going to rotate around that. So I don't like the transfer piece because it rotates. I don't like the analog because it doesn't rotate. With the system, I think it's much better to have a chairside pickup, a totally passive approach to it. In the laboratory, relieve that area, let your dentist pick it up chairside. Definitely. Now, there is a processing cap you can use, kind of like the Delrin piece I talked about for the removable locator. This will pre-relieve area inside the denture. If you're printing a denture, you can scan this piece, spray it and scan it, and that'll allow that, that access area in your printed denture base. There's 3 ways you can remove it. So the question comes up, okay, I have 4 of these green balls, that's 80 pounds of retention. You know, it's really hard to get it seated down because you have to go from posterior to anterior. Posterior, you know, we can use the opposing to kind of bite down. Anterior, you know, that's a lot of force to put 40 pounds of force on there. How do I remove that? Well, it's kind of like a zipper. You want to start on one side, remove a couple of the attachments, and then you can zipper it across. So the first idea that was brought out was a little inflatable bladder that would go, that you push underneath between the tissue and the prosthesis, and you would shoot the syringe full of water and the bladder would fill up, and the patients hated it. Patients absolutely hated it. It also was a one-time use tool at $149. Guess who else hated it? Yeah. So the next way after the bladder didn't go through was, this was Thor's hammer. And this is probably pretty close to what it looks like. I've been stopped in TSA with this thing before. They thought it was a cane or something. No, it's not that big, but it's not small. And this is actually, you know, it's like a simple crown remover. It's just leverage. This actually works beautifully where you get your metal wire underneath. This white tip is Delrin, so it's not going to damage your teeth. And you just raise it up and it pops it right up. Now, does it look fancy to the patient who spent all this money on this restoration? Not really. So there's a third system that's now out, and this is a pneumatic little trigger gun that can be used to seat, which is huge, and remove the prosthesis. So the seating part is what I'm probably more excited about, because 2 of the 3 cases I was chairside for, we had a hard time getting the anterior attachment seated. Especially if you're working with an elderly patient, lower arch, it's not like you want to, you know, detach their mandible by banging on it. That was probably a bad, you know what I mean. All right, we're getting close to that hour where I start losing any filter. Okay, so you protect your teeth, a little bit of VPS, and instead of coming at an angle, we're coming straight down. Hit the gun a couple times, easy to seat. You're always going to go posterior to anterior, 2 to 3 clicks each side, then the anterior, then you're done. To remove it, put the wire underneath, click, click, pulls it right out. So why would I use something like this? You brought up the great example earlier about doing, doing the telescopes up front. This is another option. You can do the telescopes, you can do the angled access channels, you can use FTX up front. You can use screw retain in the posterior. Now, I think to me the biggest advantage of the system is when you get that call, hey, the patient had an all-on-4 and all-on-5 and lost an implant. What do we do? This is where it comes into play. I'm going to skip this completely. This is where this comes into play. Patient lost an implant. Basically, whether this is zirconia or titanium, we need to redo the framework, right? This is going to be costly to the patient, our dentist. Here's what we do. We place an implant back in the site. We place an FTX abutment, place the housing on it. We go into our existing prosthesis. We core out an area, open it up, and we pick up the housing inside our existing prosthesis. We've salvaged the prosthesis by using an FTX. Again, we're not going to have screw access channels showing. We're going to have to seat this first. No screw access channels, but I tell you what, we didn't have to redo the framework, and the patient didn't have to be without their teeth. The FTX is a great salvage because you get those phone calls I do, what do I do now? Now, the patient's daughter's getting married in 3 days. Here's that solution. All right. 2 more minutes. I'll sit by this. This is, I think, another fun, easy solution. You have that long-term provisional, or you have that patient that wants something that is good, cheap, fast, that wants all three. So you don't have to mill this. These are the Trilor wafers, and these are great for your long-term provisionals, or if, again, if the patient wants something more economical. There's 3 different thicknesses: 3.5, 5.5, 7.5. 7.5 is awfully thick, 3.5 is awfully thin, 5.5 is probably the way to go. Basically, what you're going to do here is take your cast. Hopefully you have more than 3 implants. This is looks like one of those Nobel trefoil things that failed. See, I told you I have no filter the later we get. Sorry. We put the soft wax on here so we can see where our access channels are. Just take a carbide, open. That was supposed to be a joke, by the way. Okay. Supposed to be a carbide, open up the Trilor. Place your temp cylinders. Okay. Then what you can do is just take a pencil and draw on the Trilor what you want your framework to look like. Take your lathe, polish it down. There's your framework. This is something you can do literally in less than 30 minutes. The reason I like the Trilor, again, it's PMMA impregnated. It's going to bond to your veneering material. This is quick, simple, easy. You can use this for your analog processing as well as your digital denture processing. Now, you need to have minimum, this isn't that bad, 7 millimeters of thickness. You need to have almost a millimeter around your cylinders, maximum cantilever 10 millimeters. Not much difference in the FTX. So this was an early case we did. This was I'm not going to say the technician's name because he's been here speaking before. This was his first time doing a Trilor case. You'll see he made it probably a little big as we get in there, but he was doing a digital denture with the Colzer system. And this is a great technician too, by the way. He opened up his channels and he made his bar and then he scanned it. This is the size bar he made. Scanned it into his software. So when he printed the intaglio of his denture, this is what was relieved. So when he had his Trilor bar, printed out his denture base, printed out his teeth, assembled them, and basically took the light cure liquid from his printer to lute obviously the teeth into his denture base, as well as luting the Trilor frame into his acrylic. This is a guy that in his laboratory was charging a fortune for his big arch cases. And his comment was that he was making more money, making more profit on a case like this than he was on the 6 implant titanium bar and the Zirconia teeth and stuff like that. And he felt more comfortable with this workflow also because he could duplicate it easy enough. So I thought that was really interesting. Again, it's simple, it's easy, it can be analog or digital, and it works beautifully. So this was the final case right here. My gosh, I'm going to be on time. That never happens. All right, so here's our workflow. Minimum clearance, 4 to 5 implants. The patient can clean it. The patient will clean it. Where's our smile line, the prosthesis tissue junction? Can the patient afford it? If the patient doesn't fit all these criteria, we'll come over here. This is where we have our fixed removable. Again, this is going to require the same amount of vertical, the same amount of implants, we need adequate bone. The patient doesn't need to have the hygiene, doesn't need to require a lip line, or the lip line doesn't matter here. The hygiene doesn't matter as much. And this is the patient that needs to have the lip lines reestablished. How's that? Now, if they don't have either of these, we come down. I'm always going to recommend bars over studs pretty much. Why would you choose a bar over a stud? Who can tell me that? I'm sorry? Splinted together, that's a great answer. More money, all right, that's an answer. Not. What's the one treatment planning thing I want to look at if I have an edentulous arch, we're going to do removable. I know it's a fixed course. Number one criteria. Keep going. What kind of ridge am I looking at? If I've got a flat ridge and I put locators on there, 8-pound locators, the strongest inserts you can get, is the patient going to be happy? Absolutely not, because it's going to be moving, because there's no lateral stability. Patient's got a tall knife edge ridge, the flange of the denture can engage and it's not going to move. I could put O-rings on there. O-rings are the most resilient attachment, tons of movement. But because the patient has stability, they're going to be happy with that. So, number one indicator, bar versus stud, take a look at the ridge. Boom, you just went through the removable course. All right, so we got a couple things for you to support you when you're going through your matrix. If you don't have one of these books, it's free. It's been a labor of love over the last 5 years. It's up to 200 pages. We've got about 100 old implants in here for IDs, torque values, driver sizes and screws. Every attachment tells you how much restorative space, what kind of function. RPDs tell you what Kennedy class it goes with. If you haven't watched the Tech Talks, they're kind of fun. We're going to start having Ruben do more of those than me because I think people are tired of seeing me on the screen. Plus, I had to shave my Fu Manchu, and if you want to see me in a Fu Manchu, the last couple are kind of cool. It was one good part of COVID. It looked cool, man. Has anybody seen anyone? It was a good look. It was my opinion. Definitely not my wife, trust me. I was on the couch for about 2 months. This is something we do for you as a service. You get that x-ray, you get that case in, implant ID, attachment ID, free app. Send us a picture of the x-ray, forward us the pictures. We ID stuff. We do hundreds a day. We used to say we answer them in 5 to 10 minutes. We're getting really slow now because we're honest, we're getting overwhelmed. There's another free service we provide to you. Anyway, that's just a couple of the things we have for you here. If you want the slides, my email's super easy. When you're the fourth employee of a company, you get to choose your own email. I guess when you own the company, you can make it whatever you want. You guys are hard. I thought that was kind of funny. God, you guys are hard. All right. So that's the email. I'll be at the booth. Questions, comments, we'll clear out here. I'll be there. So thank you for staying with me. I hope you picked up some pearls. Water hose. Yes, sir. All on 4 one-day commercials on TV. So they're immediate loading most of the time the next day, within 24 hours. So the question is on the... I think we have someone who worked for a couple of years. You want to answer that? I feel like Jerry Springer. Or no? I'll be on Oprah now.
It's conversion same day. Same day surgery, conversion the same day.
So you have to run around like this now. Richard, I'm going to pass it back to you.